This is Crystal Fenn from MedPage Today. I'm here at the American College of Cardiology meeting in Chicago, where Dr. Gust Bardy presented the results of a home AED trial at a press conference this morning.
The home AED trial was NIH funded and supported by Phillips and Laerdal, and it was designed primarily to deal with the problem of sudden cardiac arrest, but had the twist to it of trying to be a public health trial, which means any result of it would be supported by Medicare and Medicaid in taking care of the patients should the trial prove to be positive in its benefit for AED therapy. The study is published today in the online version of the journal, so you can, New England Journal, so you can get details of the trial there if you want. But the goal was to address ventricular fibrillation, or the primary cause of cardiac arrest, and it occurs most often in the home. And because the mortality associated with it is approximately 10% per minute, the long-term survival of sudden death in the home is abysmal, has been so for 40 years, almost no improvement anywhere on the planet, no matter how good the medic systems are. Estimates of survival from cardiac arrest in the home are at 2%. So any effort to improve upon that would certainly add to the public health, since sudden cardiac arrest is a dominant cause of death in the Western world. So with NIH support, we instituted the trial in 2001, 7,000 patient trial, 7-country study, examining patients at modest risk of cardiac arrest. We couldn't include high-risk patients because those patients are more appropriately treated with implantable defibrillator therapy. So we chose a population who had survived and been discharged from the hospital, had survived a myocardial infarction, and in particular an anterior myocardial infarction, because at the time everything we knew predicted they would die at a rate of about 4% per year from all causes. And this study was designed to improve survival by 20% in that group. Doesn't sound large, but in this rate of death, that's a large improvement. Under the anticipation that the patients, when living with someone else, spouse or companion, and that companion was trained, would be able to rescue them better than a medic system might be able to rescue them should they have a cardiac arrest. So we randomized approximately 3,500 families into 2 groups. We didn't have a true control group. We didn't feel it was ethical to not train somebody about the problem of sudden death and how to do CPR. And so our control group was trained to do CPR and to be aware of the need to get medical attention promptly. That is, in fact, probably not normal practice in any country, to take your post-MI patients and talk to them about death and cardiac arrest. But we did that. It was actually a difficult part of the study. So we did that in the control group, and we randomized the other half to that plus a home AED, and we trained them how to deal with that. Plus we required good medical management post-MI. And our findings after over 3 years, for those of you that have seen the data, know that there was no mortality benefit, all-cause mortality benefit in the trial. And that's because of several reasons. First of all, the all-cause death rate was 1/2 of what we expected, unbelievably low, 2% death rate per year. Moreover, what we saw was that death didn't occur in the home at the rate we thought it would, and when it did occur in the home, it wasn't as witnessed as we thought it would be. Many people simply collapsed at home and died without any notice of their death. We believe the outcome is in part related to excellent beta blocker, ACE inhibitor, statin use in the 80-90% rates, aspirin use, excellent training in that regard. The people were quite compliant in their drug therapy. They had a high revascularization rate. And we believe there's something about the awareness of cardiac arrest that helped the patients, although we won't be able to prove that without digging into the data more. We believe there is an awareness issue. For example, as you might imagine, people would take a chest pain event and pay a lot more attention to it if they knew it was possibly linked to their imminent demise. So those factors probably related to the overall death rate. On the AED side, what's interesting is we did have a few uses, and when we did have uses, when patients were witness to collapse and the spouse or companion had the presence of mind to use it, outcome was excellent. We had very, very good survival in those with witnessed ventricular fibrillation, comparable to any of the prior reports looking at AED therapy. And we also had some neighbors defibrillated, bringing new meaning to knocking on the door for a cup of sugar. These folks actually came over and asked for help from their neighbors. 7 cardiac arrests, 3 were found in asystole, 4 with ventricular fibrillation. 2 of those neighbors were long-term survivors, so that's an interesting twist. No inappropriate uses by the device. Every time it was used, it worked well. One last comment is that this is a denominator study. All other AED studies were numerator studies. And so those studies should be considered differently. None of those studies really looked at all-cause mortality, in which case they may present equal difficulties improving long-term benefit.
So home AEDs appear to be effective when a shock is administered, but the likelihood that patients will need to use home AEDs is minimal. I'm Crystal Fenn, MedPage Today.